Can you guys hear me okay? I think the mic is on. Updates in pharmacy is a pretty big topic, so I kind of stuck to what I knew. I'm a pharmacist in gynecology oncology at the University of Colorado, so I'll be talking about some new treatment options in gynecology oncology. Hopefully Dr. Chan and I do not have too much overlap. So first I wanted to take a look back at the evolution of the treatment landscape, and then we'll cover those 4 new agents, starting with tisotumab vedotin, indicated for cervical cancer. We'll go over mirvetuximab. The labeled indication is there, but do note that NCCN guidelines also has it listed as a treatment option in the platinum-sensitive setting with or without bevacizumab. And then we'll talk about famtrastuzumab deruxtecan. This has a tumor-agnostic indication. And then avutometinib and defactinib. These are a dual TKI, newly approved for low-grade serous ovarian cancer that is KRAS mutated. So looking back in 2014, we had bevacizumab and PARP inhibitors make their way on our treatment landscape, and PARP inhibitors certainly have had their own evolution. And then we did have a smattering of immunotherapy make its way into the treatment landscape as well, most recently with the KEYNOTE-A18 and the RUBY trials, and 868 for cervical and endometrial cancer, but we're really gonna focus on the ADCs, or your antibody drug conjugates, and also that new TKI combination. So tisotumab vedotin, the next 3 agents are antibody drug conjugates. So as you learned in the last presentation, you have that monoclonal antibody, so that's that teal Y-shaped structure on the left-hand side of the slide. And then you have that toxic payload. Those are those pentagonal-shaped yellow. And then you have a tumor factor. That is your receptor that the antibody attaches to that allows internalization. That toxic payload is released, so that linker dissolves. And then in this case, the mechanism of action, it's a microtubule inhibitor, so it inhibits mitosis. You also have what's called a bystander effect. When you hear that, that means that toxic payload goes out of the cell and affects other cells around it, whether they're tumor cells or normal cells. And then you might also hear the DAR, or drug antibody ratio. What that is how much of that toxic payload is attached to each monoclonal antibody. I do have a little bit of trivia for each of these. This one, the toxic payload MMAE, was derived from dolistatin, which was first isolated from marine cyanobacteria. So dosing and administration, this is dosed at 2 milligrams per kilogram over 30 minutes. It does max out at 100 kilograms, and so do your dose levels below it. So you have 2 dose levels if you need to dose adjust, but you're not going to go over 100 kilograms to calculate that dose. It's given every 21 days until progression or toxicity. It's low emetogenicity, so you want to pre-medicate with a 5-HT3 inhibitor. Total chair time, therefore, is about an hour, and you do want to use a filter. This one and the next one are associated with ocular toxicities. For this agent, the ocular toxicity is considered to be on target, and what that means is there is tissue factor on the eyes, and so that's where we get that toxicity. When you hear about a toxicity that is off target, that just means that that toxic payload has gotten outside of the cell and affected the normal cells. Because of these ocular toxicities, the patients do need an eye doctor visit prior to the start of treatment and before each cycle for the first 9 cycles, at a minimum, more often if needed. And then 3 eye drops are needed, 2 that they will need to bring to infusion with them. That's that vasoconstrictor eye drop and the steroid eye drop. The vasoconstrictor, it's 3 drops, both eyes, 1 time each cycle just prior to the administration. And then that steroid eye drop is 3 times a day on days 1 through 3, including 10 minutes just before each infusion. And then they also should be using a preservative-free lubricating eye drop 4 times a day at a minimum, but more often, and that is throughout the cycle. They also want to avoid contact lenses throughout treatment, so not just the day of infusion. There is an ocular assessment form on the website for the manufacturer that you can use to communicate with the eye doctor, and that'll let you know whether you need to dose adjust. This one has a cooling eye pack that you need to use. That patient needs to have that on during the infusion, so it's placed 10 minutes before, stays on during infusion, and for 20 minutes after, so a total of an hour. The ones that we use at the U have ice in them, so they stay cold throughout treatment, but if you're using a gel type, that might need to be replaced mid-treatment so it stays cold the whole time. Adverse reactions, I won't belabor. I do want to point out peripheral neuropathy. This is from the ANOVA 301 trial. So you'll see the chemotherapy arm had low rates of neuropathy, but those agents listed below are not typically associated with neuropathy. Neuropathy median time to onset was about 2.4 months. And then those ocular toxicities that we just talked about, the typical median onset is 1.2 months. We also have some GI toxicity, not too much different from the chemotherapy arm, and very low rates of grade 3-4. Epistaxis and hemorrhage, so it works on tissue factor. That's the start of your clotting cascade. It exists in blood vessels, so that's where we get that toxicity, but rarely grade 3-4. Pneumonitis is not listed, but pneumonitis is a risk factor with all of these agents. Very low with this one. Across trials, it was 0.9%. So you can see decrease in counts, albeit lower rates of both all grades and grade 3-4, and you can also see an increase in LFTs and serum creatinine. That was pretty similar to the chemotherapy arm. Not going to belabor the dose modifications for each of these agents for the sake of time, but just know that these are in the labeling and they're pretty specific. I will point out for those ocular toxicities, it's going to depend on whether it's confluent versus non-confluent, and then also their visual acuity. So this is where that ocular toxicity assessment form from the eye doctor comes into play if you don't have availability of their note in your electronic health record. We'll move on to mirvetuximab soravtansine, indicated for ovarian cancer. The target receptor here is folate receptor alpha, and then the toxic payload is DM4 ravtansine. Trivia on that, it's a maytansinoid, which was first isolated from an Ethiopian shrub. So who says we don't give herbals? This is also a microtubule inhibitor, so inhibits mitosis, also has a bystander effect, and then your drug-to-antibody ratio is 3.5. Dosing here is 6 milligrams per kilogram. Uniquely, it's dosed on adjusted ideal body weight. So that is a specific formula that's in the labeling, but it's essentially a difference between their actual body weight. Ideal body weight, you take a percentage of that and add it back to ideal to come up with your dosing weight. Highly recommend that if you can incorporate that into your electronic ordering system to avoid errors. You can disregard that over 60 minutes. It is titrated for the first infusion. If tolerated well, future infusions are dosed at the max, which is 5 mg per minute. So for a 300 milligram dose, it would be 60 minutes, but will depend on that calculation. Given every 21 days as well. Moderate emetogenicity, so you want to do 2 agents, a 5-HT3 inhibitor and dexamethasone. The acetaminophen and diphenhydramine are in there to help prevent infusion reactions. And then you do want to use a filter with this one as well. It is a specific filter, the PES, and that has low binding to that monoclonal antibody, so more drug gets to the patient. This one also requires eye doctor visit prior to the start, but every other cycle for the first 8 cycles, and only 2 eye drops and no cooling pack needed with this one. So steroid eye drop, this is dosed more frequently. It starts the day before treatment, and it's 6 times a day for 5 days, and then 4 times a day for 4 days. 6 times a day amounts to about every 2 to 3 hours. I don't remember to do anything that often, so I usually advise patients to set an alarm on their phone to help remember so that they're adherent. And then also bringing drops to infusion, not necessarily because they have to use it in infusion, but because it is so frequent. And then also avoiding contact lenses throughout treatment. This one also has an ocular assessment form that you can use to communicate with your eye care provider. And then toxicity, so peripheral neuropathy, we see that with this agent as well, a little bit lower than that chemotherapy arm. This is from the study 0416, which is the Mirasol trial. And so you'll see at the bottom the investigator choice chemotherapy. So you did have taxane as an option here, so we do see neuropathy in that chemotherapy arm as well. Peripheral neuropathy, median time to onset was 6 weeks. And then the ocular toxicities here, do note that there are some grade 3-4 ocular toxicities associated with the agent, so keep an eye on that, pun intended. And the median time to onset for that was 5 weeks. And then you also have GI toxicities and musculoskeletal pain. Pneumonitis, median time to onset for that was a little bit later, about 18 weeks. Toxicities as far as hematologic, so you do see decreased counts with this one, lower rates for both all grades and grade 3-4 compared to chemotherapy. You can also see LFT elevation, but rarely grade 3-4. Similar to tisotumab, the keratitis keratopathy is going to depend on whether you have confluent versus non-confluent changes of the cornea, and also what their visual acuity change is. Moving on to FAM, trastuzumab deruxtecan, our third antibody drug conjugate. So the receptor here is HER2, and then your toxic payload is DXD. This is a topoisomerase 1 inhibitor. So what that does, the topoisomerase is that enzyme that helps relax the DNA to allow for replication and transcription. So you inhibit that, it can't replicate itself. The cell dies off. You have that bystander effect. Your drug antibody ratio here is 8. Trivia on this one, these were isolated from the Camptotheca tree, so think irinotecan, topotecan, and those grow in southern Asia. Dosing here, 5.4 milligrams per kilogram every 21 days. Your first infusion will be over 90 minutes, and then subsequent infusions, if they tolerate that, is over 30 minutes. There's 2 dose levels to go down should you need to dose modify, and you go until progression or unacceptable toxicity. This one is highly emetogenic, so you do want to give 3 agents for pre-medications. So your 5-HT3 inhibitor, dexamethasone, and your NK1 antagonist. Chair time, obviously a little bit longer for that first one. You also want to use that special PES filter. Because of the cardiotoxicity risk with the agent, you do want to do left ejection fraction at baseline and then at regular intervals. Toxicities here, so all grades of the GI side effects, not surprisingly high. That's why we use that highly emetogenic regimen. And you did have some grade 3-4 nausea, so do note that. Alopecia, for all 3 of these agents, alopecia is usually not separated into grade 1 or 2. So it's hard to counsel patients. So grade 1 is less than 50% of hair loss. Grade 2 is greater than 50% of hair loss. So I usually counsel patients that it's a possibility, and how much hair they'll lose really varies from patient to patient. Interstitial lung disease is also seen with this agent. Median time to onset for that was 5.5 months. Do note that the numbers here are from a conglomerate of studies. Those are listed there at the bottom of the slide. And then you can see decreased counts. Look at the rates of grade 3-4, so really keeping an eye on their counts and dose adjusting if you need to. You can also see LFT elevation with this agent. Interstitial lung disease, so a little bit different than the other 2 agents. When you're asymptomatic, so if it's caught on a scan, they still want you to interrupt treatment. So note that with the other 2 agents at grade 1, you just monitor. Also dosing adjustments for those decreased counts. And then also dosing adjustments for any change in left ventricular dysfunction. So going by their baseline, how much it's decreased, but also what range it's in will determine what your dose modification will be. Lastly, we'll talk about avutometinib and defactinib dual TKI. So the avutometinib, if you look at that left-hand side of the slide, that's your MAPK pathway. So it's a dual clamp on MEK and RAF. The resistance mechanism to that is that second pathway where defactinib works. So it's a FAK inhibitor. So it's kind of a dual hit. Dosing and administration is a little bit complicated, so making sure you're handing out a calendar with this one. Patients will take both agents for 3 weeks on and 1 week off. For avutometinib, it's 3.2 milligrams, which is 4 capsules only on day 1 and day 4. And then for the defactinib, it's 200 milligrams, 1 tablet, twice a day. There's only 1 dose level to go down, and you do dose reduce both agents. Both agents should be refrigerated and both agents taken with food. There are ophthotoxicities with this one as well, so you want that baseline exam and then before the second cycle and every 3 cycles. Skin prophylaxis is paramount. There's high rates of rash and acneiform rash. The manufacturer recommends a topical steroid, oral antibiotics like minocycline or doxycycline, and then sunscreen. And then high rates of LFT and CPK elevation, so we do monitor those closely for the first 4 cycles, so at baseline and every 15 days. High rates of toxicities as far as GI toxicities, you do have grade 3-4 diarrhea in 7% of patients. This is from your RAMP 201 trial. And then high rates of fatigue. I will note that a lot of patients did have to interrupt treatment in the study, so don't be shy if you do need to interrupt. And then dermatitis and rash, median time to onset for those skin reactions was 2 weeks. And then median time to onset for your eye disorders, which can include vitreoretinal disorders. For asymptomatic eye toxicities was seen median time of onset of 5 days. Asymptomatic was a little bit longer, around 4 months. And then you can see retinal detachment with this. Median time to onset with retinal detachment was about a month. You also see hemorrhage with this one, and I found pretty interesting. You can also see neuropathy with it, which is unusual for an oral agent. High rates of CPK and LFT elevation, and then you can also see decreased counts with this one, but those were rarely grade 3 or 4. I have 3 pages or 3 slides of how to dose adjust, but do note for the ocular toxicities, in addition to the ones that we saw for your antibody drug conjugates, they also have specific recommendations for that RPE detachment. Also dose modifications for rash, hepatotoxicity, increased CPK, and other adverse reactions. Thanks so much for your attention. I think we have about 3 or 4 minutes for questions, if anyone has questions. Yes?
Thank you. Any questions?
So bystander effect is when that toxic payload gets out of the intended cell and affects normal cells or cancer cells in the vicinity.
Thank you. Any other questions? No? Okay.
Thank you
So much.